research I did along the way because these things were interesting, or I had some issues and I wasn't really understanding what was going on. And then I'll go through some of those symptoms and kind of how I look at those when patients come in with those symptoms that I had. So 31-year-old male, chief complaint was glute pain with sitting. So I never had any pain with activity. I could go run, I could go snowboard all weekend. I would just pay for it the following day. So if I went snowboarding on a Sunday, Monday was going to be a rough day at work because I don't sit that much, so it wasn't a big deal. I had pain for about 2 years, and it just progressively got worse. I could go from sitting, I couldn't even make it to work in my car, which is about a 3.5-mile drive, and I would get pain immediately from sitting in the car. I had no pain with impingement activity, so when I went in to see Dr. White the first time, he did an impingement test on me, and so nothing happened really. So I was one of those cases that really didn't follow his algorithm. So we did an MRI, and that confirmed that I did have a labral tear, but he was still a little apprehensive because of where my symptoms were at, and that was in my glute. So we did a diagnostic injection to confirm, and that pretty much took care of all my pain with that. And that lasted for about 4 hours, and so I did some things that day that I probably wouldn't normally do, and I didn't have any pain when I did them. Pre-surgery symptoms, I had poor glute complex and endurance. So if I were to do a workout, especially like single leg lunges or squats, I could not do the same amount of reps on one side versus the other. So my right side was my surgical side. I had quite a bit of glute complex atrophy. I noticed this one morning getting ready for work. I noticed I had a large divot on the right side of my hip compared to my left, and that was where my glute med used to be, and it really wasn't there much anymore. And just the good old field test. Faber was increased on the right. I don't know if you are familiar with using the Faber. As far as a Faber for your lower back, Dr. Philippon uses the Faber as a screening test that is indicative of labral tear. They usually measure from the table when you're laying supine the difference. And if you usually have a 5-centimeter difference, then it's indicative of a labral tear. I don't think that it's the labral tear that actually causes this. I think it's the pain or the compensation from your adductors and the TFL. So I did have a lot of hypertrophy of my adductors and the TFL. And then I had a slight antalgic gait, and that was increased pelvic sway. So when I would walk, my pelvis would rock anteriorly. So that was mainly my preoperative symptoms. Post-surgery symptoms, just overall soreness, hip flexor pain and tightness. I never had any anterior pain, so I didn't really know what that was until I had that surgery and I had to get out of bed the first day. And that did not feel great. And so your hip just feels really full. Going along, I had, again, adductor and TFL compensation. I was very tight in my external rotators and abduction muscles, and then I had difficulty with glute control and pain. So the first day that I tried to do an isometric in my glute, I couldn't even do it because of so much pressure and pain anteriorly. So be careful with your patients. Not a lot of people have that, and they don't need to do a glute maximal contraction. You just want them to have it cut on and cut off. And then a lot of hamstring tightness because my glute did not want to help me extend past neutral for the first couple of weeks. So going into your patients, and when you get your history or they come to you either preoperative or postoperatively, is definitely look at age. And we know that adolescent females tend to be the ones that have the most issue with this. And so go slow with them. Sex again. Males usually do really well with this surgery. They don't really have any complications. They can. I think mainly males probably underreport because they don't want you to know how much pain they are in some cases, so be careful with that. Pre-surgery pain and location. So when I first interview a patient, I always ask them, what was your pain previous to surgery and where was it at? And where did it start? So did it start more laterally and move anteriorly, or did it start in their glute and move more laterally? Just kind of those symptoms, because with those patients you want to pay attention when you're progressing their exercise routine, especially with your repairs. Are you reproducing their previous symptoms? Because that's going to be very discouraging for your patients if they start to get that little bit of pain back in that area. People with posterior pain, I feel, progress a lot faster because they're anterior. They never had it, so they're not really apprehensive about things. And then the cause of their pain. Did they only have pain during running? If that was the case, then they're probably going to progress pretty fast. if they were somebody that they couldn't sit more than 15 minutes or a long day at the office or whatever. So just know how susceptible and how sensitive they were. And then length of signs and symptoms. So are they less than 6 months, greater than 2 years, that kind of thing, and then an articular lesion. So a lot of the times Dr. White does a really good job of drawing on the back a nice illustration for his patients. I tend to look at those and see where there may have been some chondral wearing or on the articular surface of the femur, because there are some studies out there that show that people with articular lesions, whatever grade they may, from 1 to 4, they progress a lot slower. Most all people do have some type of articular lesion, but if it's a 3 or something, just keep that in mind. The number of surgeries, of course, if this is their 4th or 3rd hip surgery, and Dr. White's just done a reconstruction on them, they're going to have a lot of compensation patterns that are going to take a long time for you to maybe pick up on, but just assume that anything that can go wrong will probably go wrong with them at some point in time, whether it's core weakness, glute weakness, compensation in muscles that you're not accustomed to seeing. And then, of course, repair versus reconstruction. The repairs, they're going to let you know if they're painful. The reconstructions won't. Just like Dr. White said, at 2 months, they're feeling really good, and they're going to try to test it and do some things, but we don't know how well this reincorporates. We know with the repair, based on some ovine studies that Dr. Philippon did, that about 12 weeks, the repairs are, if nothing goes wrong, that they're about 80 to 90% healed. Reconstructions, we don't know if ever or how much it does reincorporate and what rate, so just keep that in mind. There was a study just released out of Australia. I just got it today. A guy did 6 revisions, but he put in total hips, and he did a histology sectioning of the labrum, and the labrum at 10 months is really well healed. The problem with those patients is they had a microfracture, and the microfracture just didn't take, and because of age, they were in that 58 to 65-year-old range. So just keep that in mind. Looking at length of signs and symptoms, there was this paper that I found, and we see A, B, and C here is kind of how they divided up the cohort. A was anything less than 6 months, B was anything from greater than 6 months to 2 years, and then C is anything greater than 2 years on to 3 years. So we have pretty much where all our patients fall is in category B. We usually see people that are right about the 2-year mark. And so they're pretty evenly distributed, more females and males in the overall thing. And then not many of them had chondral lesions, and then almost of them all had a labral tear, or was identified with a labral tear. And then this is their the study with their the Harris hip score, and you can see the p-value here. As far as the groups, they're pretty similar, except when you get down here to preoperative, postoperative, as you follow that on. And you can see that the p-values way down there at the bottom for 2 years, which is A versus B, they're relatively the same. You wouldn't statistically think that those are that different. But when you get into the group A versus C or B versus C, there's a pretty significant difference in how those people play out over 2 to 3 years, which goes on to what Dr. White's doing. These people in group C were probably better candidates for reconstruction. So just keep that in mind, that if you have somebody that's 3 or 4 years out, that they may not get where they want to be, especially with our active population. So just keep that in mind. And then this was the revision rate. Of course, in A, they had less than 4%, which is where kind of Dr. White falls. And then groups B and C were up around 10 and 14. So just keep that in mind. So phase 1 is after surgery. It's pretty much the same as it always is. Protect the surgery, decrease inflammation and swelling, restore range of motion within limits with circumduction, and muscle re-education and control. And then phase 1 problems. Most people get out of phase 1 with no issues. This is pretty much, they're just moving along. You're trying to get them to where they can wean off crutches at 4 weeks. Main things is glute and iliopsoas inhibition, tight external rotators, hip flexor pain, tight hip extension, and a pinch in the joint. Not everybody has a pinch, but the most cautionary one I would tell you is the pinch in the joint, because that really discourages a lot of people, and they get scared of it because that was their prime symptom before. But just assure them that, Dr. White was in there for 4 hours banging on the front of your joint, so it's going to be a little bruised for a little bit. But that'll calm down in a couple weeks. And then tight ER muscles. I didn't really give this a whole lot of thought before I had surgery, I would work on a little bit of internal rotation, but I was never really concerned with internal rotation because it always came back, and it usually comes back better because he takes a large section out of the femoral neck junction, and so they have better internal rotation usually on their surgical side. But your external rotators get really tight, and a lot of the times I think that's the problem with progressing patients is they're so tight that they're not functioning properly, so the adductors, the TFL, and some other muscles that we'll look at end up taking up a lot of the slack. So phase 2 or flare-up central. This is kind of the phase that if you get out of, you're probably going to be fine. If you get them to phase 3 and you start to do running or whatever high-level activity it is that they want to do, then you're probably safe. But phase 2 is where I think most of the people we never get out. They're either 4 weeks to 12 weeks or it's forever. You've been treating them for 16 weeks and nothing has changed. You're doing the same exercises and you're running out of things to try with that patient. So just be careful in this phase. Normalize gait, restore full range of motion, neuromuscular control, proprioception, and then functional exercises. Phase 2 problems. Adductor pain, medial glute fold pain, anterior hip just pain, so if you kind of come up a little bit more laterally, gait issues, and then that mini joint flare or effusion that it's hard to detect because there's no way to do a sweep test or any test that you can do for the knee or the ankle that you can obviously see that there's a lot of swelling or effusion in those joints. So adductor and TFL hypertrophy is a lot of what we see. And I think it's compensation due to Iliopsoas weakness and pain, plus poor glute complex control. So there's not really too many EMG studies out here that deal with this, and then the few that are, Dr. Philippon did one, and he just looked at basic exercises and not gait or anything like that. And then you have the in vivo prosthesis studies with hip, and it looks at weight bearing and non-weight bearing, and those are really good studies for weight bearing, but they don't really show us any exercises. The couple of exercises they do aren't tested in any reality that we would actually ever use. Hence the one that has you lay in side lying and tests your abduction and says press as hard as you can. I don't think I've ever had anybody do that exercise. We do maybe a little bit of active abduction to get the glute med, but you would never press that hard. So they looked at that. So I found this study. I did a lot of looking and trying to find a study that would kind of back up what I was already thinking. And so Kara, whoever she is, they did a 3D model study, and what they did is they took some EMG data from 6 patients just to get some normalized EMG, and then they plugged it into a 3D model. And so they did one exercise that we will never do, which is a straight leg raise. And they, all these muscles are displayed of the forces they did. But what they did in this study was they took the Iliopsoas at what it was at a normal, say 100%, and then they cut it down to 50%, 25%, and then 5% of its total force that it could produce. And so when you did that, if you look at supine hip flexion on the right and then prone extension, we'll talk about that in a minute, you can see that the total force starting at 10 degrees of extension going into 30 degrees of flexion, so they kind of were hanging off the edge of the table, it's increasing at that most neutral point is kind of the high, and then here's how much not distraction, but compression within the joint, and then anterior forces, and then nothing really happened immediately. So I didn't think that was all that irregular of what I thought it would find. I'm like, yeah, you do a straight leg raise, you're going to cause a lot more joint force. And so no big deal, I'm never going to do that exercise. And then in prone hip extension, it was kind of the opposite of that. So they took the glute, found the EMG data, and then they did the same thing, cut it by 50, 25, and then 5% of what it totally could do. And can't really see it well, but the black line is the normal, blue line is, this one is the without the glute, and then the other one on the other side is they took the hamstring out as well. And so, didn't really tell me anything I didn't already know. Other than in those instances, when you start to decrease, you actually increase the amount of force at neutral. So if you look at hip neutral, 58.1% increase in over normative force with decreased iliopsoas. So you're causing a lot more force in the anterior portion of the hip, which is a problem when you're trying to get a labrum to heal or we're worried about hip flexor tendonitis. And then if you did it in hip neutral and they took the rectus, the TFL, and the Sartorius out, you only had a 6.8% increase. And I think our big problem is when he does the surgery, the the hip flexor is just collateral damage. It's just in the way. You can't do anything about it to really protect it, and so it gets super irritated. So when you see those patients that come to you as they're weaning off crutches or they did too much walking and they're like, well, my adductor hurts, or they're pointing to kind of their pubic symphysis or their gluteal fold, it's probably because these areas, they're overusing those three muscles to do everything. So what they looked at, and we'll kind of go past this part because I've already explained. So here's the compensation patterns that they got. So condition 1 versus condition 4. So condition 1 is the normal forces. So if you look at prone hip extension, the semimembranosus, TFL, and the Sartorius don't really do a whole lot in extension. But then you take the glute out and you decrease it, and we can only do 5% of what it's supposed to do. You see that your semimembranosus, your TFL, and your Sartorius increase by a factor of almost 100%, which is almost theoretically impossible. And then you do the same thing in hip flexion, and then you see the TFL, the Sartorius, and the adductor, relatively small, just stabilizers like you'd expect them to be. And then you come over here to condition 4, and they've almost doubled or tripled in value. So they're doing something they're not intended to do, plus they're creating shear because they're not moving the joint in their traditional just single plane. So it kind of led me to say, okay, this is going to be an issue, but what implications does this have? So if you look at somebody that's walking, they spend about 60% of their time in a stance phase and 40% of time in swing phase. But then when you start to speed that patient up and get them into running or sprinting, then it goes the other way. And so you go from almost 55% of swing to 45% stance, all the way up to Olympic sprinters where they're doing 80% of swing and 20% of stance phase. So when you get to your running progressions and your person goes out and they said, oh, it felt kind of great, they do it 2 or 3 times and they come back with all this adductor pain, this may be your problem because we don't really ever address the hip flexor to do that much repetitive motion. And so that, I think, is a problem that is occurring, and me and Dr. White have talked about this, is does hip flexor tendinitis exist in the capacity that we think it does? We think it's that irritation of the hip flexor to the anterior portion of the joint, because some of the diagnostic injections he does later on, the pain goes away, so it's probably not the hip flexor. But I think the hip flexor does have to be strengthened at a point, but when and where and how much is still yet to be determined. So this is just looking. This, again, when they cut the hamstring down as far as 50%, you can see that they're relatively the same. So we need both of these. So don't neglect one trying to get the other. And so you need to work on those. But when your glute is weak, you'll have that person that comes in later down the road and they say, it hurts right here. And you're like, well, why does it hurt right there? Well, we know that that's where that portion of the hamstring that's trying to help you extend connects at. And so that may be an area to address. And here, hip pain or a pinch in the joint. So their pinch kind of cleared up for a little bit, and then all of a sudden it comes back. These are the kind of my thinking of what contributes to that. Is it the Sartorius? Is it the pectineus? Iliopsoas? Or is it the capsule? It's usually one of those 4. So we're going to kind of go how I tease those out as far as that's concerned. So I don't know how many of you use quadruped rocking to help restore range of motion. It's something that we do quite often. So I usually stick a person in quadruped rocking and have them do 10 reps and see if the pinch is there. If the pinch is not there, then I'm like, good, it's probably not that flared up. If it is there, then I'm thinking that it is really flared up, because usually when you put them in weight bearing and you have them move around, it puts the joint in a proper spot, and maybe something was just moving wrong. So if that's pinchy, then I put them on their back and I test hip flexion. Well, hip flexion is always pinchy. But when I do test hip flexion, I do it eccentrically. So I have them push into me, and then I load it as far as they'll let me go, and I tell them to tell me when they have the pinch, and I compare the two. If the pinch goes away, then more than likely I'm thinking that it's soft tissue, and it's probably either Sartorius or your rectus or potentially iliopsoas. And then testing extension as well, and testing the quality extension passively. So can you extend the left or the right or the uninvolved and the involved, and do they feel like they go symmetrically, or does one of them feel kind of sticky, like it doesn't want to move in that direction? And so that can kind of let you know, is it capsule or iliopsoas, because they usually don't have any problem in their Sartorius or the pectineus with hip extension. It's one of the larger groups, which is usually your iliopsoas or the capsule. And then again, I use modified Faber a lot. So This one it's similar to the favorite. I just don't put their knee on their foot on their knee. And so I have them go into that position and drop out and kind of comparatively look at and see if they get full range of motion, and do they have any catching, and where is that catching at? You know, sometimes they'll point right to their adductor, so you assume their adductor, or they'll point up high to their kind of TFL area, and that'll let me know that it probably could be somewhere around their pectineus, and it's just tight and it's creating the joint and it's pushing it up. And so I use that a lot in my daily treating. I check it and see, well, how does this feel compared to yesterday? And then palpation, I use this quite a bit, especially with the iliopsoas. It gets bunched up a lot of the time, and so palpating and comparative to see how sensitive it is. I'm sure we've all felt that muscle that has that hot spot or trigger point, and that's kind of what I'm looking for. So either the iliopsoas isn't working all that well, and so you'll test it there, and you just won't feel anything. So I put them in, you know, the 90-90 hip flexion, palpate, have them give me a little resistance. Do I feel anything? I also palpate at the same time as where the rectus and the sartorius come up, because they kind of overlap. And I'll put 1 finger or 3 fingers on the iliopsoas and 2 fingers on the sartorius and the rectus, and you'll feel a very big difference, especially if it's overdeveloped or hypertrophy. And then you check the other side, and then you let the patient feel, and they'll notice, wow, this does not feel. And so that's a lot of the time what that pinch can be. It's just rolling up in the spot of where the ASIS and the front of your leg meet. It's kind of like having a big shirt on and then trying to bend your arm. It just doesn't want to go there, and it's not that there's anything going on with the labrum. And then piriformis stretch, you know, where you have them kind of in this position. I'll actually take them into that position and see where they feel it at. Do they feel it more anteriorly, which is not normal, or do they feel it posteriorly where I expect them to? If they don't feel it more anterior, if they feel it more anteriorly, I'm going to put a little bit of compression on them and see if it moves to their glute. If it moves to their glute, I just think that everything anteriorly is really tight, or they don't have a very good glute complex to keep everything where it needs to be. And so I'm going to address those areas. And how am I going to address those areas? That's kind of up to you to decide. If they're far enough out and you feel comfortable enough with dry needling, then maybe that's something you should do. Soft tissue, or they may be so sensitive that sometimes you just have to stick an ionto patch on them, and hopefully it just calms down in that origin portion, because it is so tender and sensitive. And then another one is the posterior deep rotators. How I usually test this is I have them lay on their involved side, and I just have them externally rotate their foot. But what I do is I make them do a set of 30, and then I have them test the other side. In most cases, they're going to be able to do about 10. And that's just because we don't work on those, or something happens and they get flared up and they stop working. I think that's one of the things that we kind of neglect a lot of the time. But what they'll try to do is they'll actually, if they're laying on the plinth like this, is they'll lift their leg up and recruit their adductor. So you have to watch out for that, because they'll do the first 5, and then the second 5, their leg will be off the table. And so posterior deep rotators, I think, are one of those things that just, it's kind of like the cuff. You have to do low load, high rep just to get them stronger. And then the last one is TA control. A lot of the times people, we kind of overlook it, or we work on it the first couple weeks, and it feels, they're like, oh yeah, I can do this all day long. And so you assume that they're still doing it, and then you go back and check at 6 to 8 weeks, and it's not even working, and you're like, what have you been using to do all these exercises at the beginning? They're probably, their obliques and their rectus abdominis are probably tender to the touch, because they've overused them so much. And so moving on, so where do we go from here? So we've got some good information as far as what does the hip flexor do. I don't think anybody doubts that we should continue to do posterior chain stuff. And then when do we start that hip flexor strengthening? I think that is something that I've seen with more of my higher level patients down the road, is we didn't really ever address this, and maybe that's the problem with the adductor and all the compensation we see. Like Dr. White said, is that people are it's not that their hip flexor is weak, you can test it, it just is not ready to do a repetitive motion that much. And then what should we use for a criteria to return to sport? Some of the people I work with, we'd use the sport test, and I think that's great at testing the posterior chain. I can't ever tell you the last time I did a hip sport test, because I don't use it all that often, and I don't know how many of you are familiar with it, but it's a lot of single knee bends, a lot of lateral agility, some pivoting and twisting, and most people, by the time they take it, they're good to go. But I think one of the things we neglect is the iliopsoas, especially for as many runners that we have and want to get back to running, or some type of soccer or whatever it involves that's very much large open chain when they start to play competitively. So that's kind of my gist of everything as far as the things that I've questions that I've tried to answer from here. So does anybody have any questions?
So what did you think as a patient, having a reconstruction compared to what you've seen with repairs? Was there things that surprised you through the recovery that were different, or was it pretty uniform and unexpected?
It was pretty uniform as far as all the things that I anticipated. I didn't really have a lot of pain, so I lost a lot of sympathy for some patients that come into me early on, but that was just me. But I've seen weakness in all the problems that I've seen in patients I've had. So, and some of them that maybe that I didn't see quite correctly, that I understand a little bit more. So I go address those things, especially with the deep rotators. I think I overlooked those a lot, and so I start to address those a little bit more and earlier on. We've done it in a certain fashion, whether you do stool rotations or you have them lay prone and do that, but I don't really think we do the reps or the sets that are necessary to really strengthen those small little endurance muscles.
When did you go back to work?
I went back to work. I had 8 weeks off, and I went back at 8 weeks.
And when did you go off the crutches?
I went off the crutches at 4 weeks. But I did a lot of pool work. I was probably in the pool 5 days a week, at least, and so I was walking normally in the pool, and I would increase my lappage each week, so that because I knew I needed to be off crutches at that 4-week mark.
And when you went back to work, did you go, I'm guessing you're full-time, did you go back part-time?
No, I went day 9, first week, I went back full-time. Luckily, I didn't have a full load that first week, but I saw about 10 patients a day. I did get pretty sore that first week. I did have to take some ibuprofen just to kind of get through the day, but it wasn't really joint soreness. It was just standing on my feet soreness. And then I got really sore in my back because I just didn't have the endurance to do the things that I needed to do. It's getting there.
When you get tight, do you notice there's more soft tissue or more capsule? Like when you needed to get work done?
I would probably say it was probably more soft tissue for me, and that was just because I think everything gets tight. I don't know how much capsular tightness with the way that Dr. White just kind of sews your capsule back together neatly, as opposed to trying to plicate it to make you any tighter with some of the other surgeons we've seen that tightened up. So I don't know that I actually have any capsular tightness.